Meeting. Today I'm pleased to introduce Mr. Carl Barton. He is a Director of Business Development from TeamPraxis. He has had 14 years of experience in the IT industry and 10 of those in the health information technology area. Today he is here to give us a presentation on technology and Hawaii's independent physician. He'll be talking about EMR and EHR, meaningful use, and how it affects our physicians here on the islands. I'd like to welcome Mr. Barton. Thank you.
Thank you very much, John. Thank you very much, and thank you everybody for having me. I think it's really great that there are these sub-area councils that are really getting together. I know we're all aware, tremendous time for change in healthcare, and there's a lot of urgency to make sure that we make a difference and save costs. So that's a lot of what this presentation talks about, how you can leverage technology to do that and how this really impacts the independent physician. So have quite a few slides, so I'll be going through them. A lot of them are just data, so I'll get through them pretty quickly. But I'm going to go ahead and start out with a little bit about TeamPraxis. So this is our 20th anniversary year, so we're really excited about that. We started as a practice management company that did medical billing services, revenue cycle management. We've evolved into now the largest EHR provider for independent physicians in Hawaii. We have over 220 physicians on our enterprise EHR, and we have an implementation queue that's full too, so that's increasing very quickly. And we also are a software development company. We actually have a national and a local side of our business. So they really work to complement each other, and I'll get in a little more detail about that later. So this is a little bit about our timeline. Our revenue cycle management started in 1992. We became a software development company when we started with ConnexMD, which developed that to help practices with a turnkey way of managing their practice. Then in 2005, we became the exclusive for Allscripts to provide enterprise EHR in Hawaii. And then here we began to leverage our software development team towards quality reporting. So that's been our timeline, and now we're really focused on this population health management and the reduction of cost, improvement of quality. A little bit about Allscripts, our partner, and they're the market leader nationwide. They've got a huge footprint. A year and a half ago, they merged with Eclipsys, which gave them a large presence in the hospital market as well. They'd always had a really big presence in the ambulatory market. So actually our software development efforts utilizes Allscripts as a distribution partner for that quality software, and that's what we're going to be talking about with the qualifying therapeutic grant. So the overview of what we're going to do is we're going to start off with just nationwide and Hawaii trends. It's going to be very data heavy there, and then we're going to talk about this grant tax credit that we received, and then we're going to talk about how this impacts Hawaii's independent physicians. So we'll start it off with the nationwide and healthcare trends. And first off, this Health Leaders Media 2012 survey is a good opportunity to see what's on the mind of health leaders out there. And we can see that these top three, they're really around healthcare improvement and business improvement. And those really are essential to adapting to new payment models, accountable care organizations, moving towards value-based purchasing. Also, this is more of a business relationship area where it becomes more important for the hospitals to reach out to independent physician associations, independent physicians, where a huge percentage of the care across the country is delivered there. So for these accountable care organizations to be effective, they really have to think about new strategies for partnerships. And lastly, you see technology, and this is in order. Technology is 6 on the list. So it's not at the top, but really technology is what facilitates a lot of these improvements. And that's the area where TeamPraxis is focused. And nationally, we're focused on that area. Locally, we're focused on helping independent physicians, which there's a lot of unique challenges for the independent physician that has to run their own business and provide care. So to talk a little bit about the problems, here we go. Bottom 50%. Is 2.9% consumption of the healthcare resources, right? These numbers are pretty amazing and comes from Kaiser. So even when we get into the the top 20% of consumers. So 20% of the people consume 80% of the healthcare resources. And what is the reasons for that? And really multiple chronic conditions. And when we look at this, this is a great presentation that you can find, and you can actually find the video where he walks through the presentation on this website, but talking about the high-risk patients in ACOs and how to manage those. And this data to me is really great, where you say 4+ chronic conditions account for 80% of Medicare spending. So if you can just pull in those outliers, you save a huge amount of costs nationwide. So here we can see similar data that says 93% of Medicare's fee-for-service expenditures go to those with multiple chronic conditions. And nationwide, 1 in 4 Americans has multiple chronic conditions. 2 in 3 of those over 65 has multiple chronic conditions. And when you're talking about people with multiple chronic conditions, there's a lot more demands on coordination of care. It's really where technology can come in to help facilitate smoother transitions in care. Now, I can't do it alone. You can't just implement the technology and walk away and expect it's all going to be better. You've got to train the clinical staff, the physicians. You've got to implement workflows. You've got to put the right partnerships in place. But technology is definitely part of the foundation of making this feasible to get accomplished. So this brings us to the 2009 American Recovery and Reinvestment Act, specifically the HITECH Act, that put in meaningful use of a certified EHR. And we can see here that the numbers, 44,000 for Medicare, just over 63,000 for Medicaid. It put out 25 measures, 15 of which were core. And so what's the impact of this been on national EMR EHR adoption? Well, really, the trend is just continuing. So from this chart, we can see it was already a strong trend and it's continued. But really what it's done is it's made these systems a lot more consistent towards the top-down demands that Medicare has put on them. So there's a positive, because I think consistency is great, but then those top-down demands, they're always not aligned with what the physician is going to need the most. And when we come to independent physicians, to help them more proactively manage these chronic diseases that are the problem. That's really where the low-hanging fruit of the cost savings is going to be. So we can see here just EMR EHR adoption, nationwide average, and we can see Hawaii is doing well, and we're beating the nationwide average as far as adoption. So as far as meaningful use, the blue is 2011, the blue is 2010, the green is 2011. So we can see that there was uncertainty on whether physicians were going to apply for meaningful use. Most of them went this way in 2011, that said, okay, the uncertainty dropped, then more said we're going to apply for meaningful use. But some just said, you know what, I'm probably near retirement, so I don't think this is worth it for me, or maybe had other reasons that they weren't going to do it. So that's what we're seeing on that side. But talking about health information technology as a whole, the EHR is a small part of it. It's interfaced with the practice management system, where you're going to have your claims data, you're going to submit that data to your payers. The EHR, the real value of the EHR is the rich clinical data, but oftentimes it doesn't have the sophisticated reporting that you need in the EHR in order to really do population health management. Now, a lot of the EHRs where they've gotten a lot better, and part of the Medicare measures were to implement a clinical decision support rule. Well, they've gotten a lot better there. So at the point of care, there is clinical decision support, but the population health management, what about the patients you don't see? And that's where a lot of those costs are. The patients that you didn't see for 10 years that had multiple chronic conditions that all of a sudden have expensive complications because they were diabetics, they didn't control it, so they end up going blind or having kidney problems and end up being very expensive in the long run. So as we move down, the informatics and analytics and healthcare information exchange really starts to pull the silos up to a higher level where you can see, all right, connect these independent physicians, connect the hospitals. And that's really essential to making accountable care organizations work, because you really, as well as the healthcare analytics, you get like business analytics there that is going to be essential to really implementing these shared savings, these risk-sharing agreements. And then patient portal, lastly, so much of this is about engaging the patient. If we can't change patient habits, if we can't reduce risk factors, if we can't help these people with multiple chronic diseases manage their conditions, then we're not going to cut the cost. We're not going to get this low-hanging fruit. So the patient portal becomes very important as far as engaging the patient. So effectiveness of technology. I think this is really great information that we're seeing now. This comes from a study from the ONC, and they found 92% of articles, they reviewed 154 articles, found benefits for health information technology. So that's very encouraging. You will run across ones that are negative, and when I go out and talk to physicians that are resistant, they love to point out the last negative article that they read, you know? I just read this article, and so when I saw this, I was like, oh, this is awesome, because I see negative ones too, but then I'm like, oh, I see a lot more positive than negative ones. So it was great for me to see this information come out and say, oh, there's a lot more positive than negative information coming out about health information technology and its impact. So then, what is the role of health information technology? And like I said, it's more of a foundation that facilitates change. When we talked about the business analytics, it can help with the accountable care organization. For a patient-centered medical home, it can help you with the reporting. It can deliver registries to a physician. It can help you manage those patients that you don't see, you know? The clinical decision support can help you with the patients you do see, but what about those patients that selected you as their primary care physician for an HMO, or they're on a PPO and they decided to come to you more than any other primary care physician? Well, if they haven't shown up in the last year, how do you know about them and their health, their diabetes, their heart disease? These chronic conditions could be a problem. So that's really where the health information technology facilitates accountable care organizations, facilitates patient-centered medical home, facilitates reduction in costs, engaging patients. Doesn't make it happen at all. So as far as accountable care organizations, I'm not going to spend too much time on this. I know I talked about it a little already, but really where I want to focus in here, we talked about the role of technology. So as far as it creating a new healthcare market, and that's really what we see. The healthcare market is based on the value-based purchasing. And right now, anyone can play in that, and everyone is figuring out, okay, how do I strategically align partnerships? How do I think outside the box about how care is delivered? And that's one of the reasons we saw that priority about physician-hospital alignment, because everyone's rethinking their partnerships and how they're going to create accountable organizations. Can they include independent physician associations? Can hospitals collaborate with independent physicians directly? So that's really where I see the impact here, but I'm a little more interested on the role of PCMH. And you know, the role of PCMH is really a building block. It's got a lot of mileage on it as far as studies, and it's been proven to show improvements in quality. So as far as accountable care organizations, how are you going to share risk? How are you going to share savings? How are you going to take the risk of loss? You're going to do it through a model that's proven to show that it's been able to reduce costs. It's been able to get these low-hanging fruit that are the chronic care conditions that drive up costs. So with that, we'll talk about some nationwide successes. So Community Care of North Carolina, and actually there was at the state capitol, Community Care of North Carolina just came out, Vermont Blueprint for Health, and I forget the last one. I think it was ERX Ante, but really good presentations. And you know, I had heard about Community Care of North Carolina before, so it was really good to hear them come out and speak. And the biggest thing that I took away from that, I mean, we can look at this as great data, but the biggest thing I took away from that is getting physician buy-in. And that's what I see every day on this independent physician level. You have to get buy-in. And they started this Medicaid program in a small area, and this has been going on for years. So they started this Medicaid area in a small program. They proved it. They got buy-in. It added care coordination services, additional services to the independent physician. But it was crucial for them to get buy-in and show a success in a small area and then spread that out across the state. And the result of that, over 6 years, almost $1 billion savings, you know, and a lot of results in the decrease hospitalizations for asthma. And as we come down to this Minnesota Health Partners Medical Group, we can see there's great reduction in emergency department visits, which is a big push for healthcare reform. So readmissions especially. So in hospital admissions per enrollee, there were significant decreases. And we can see overall, they reduced to 92% of state average, where they started at 100% of it. So back to what the point of this was, PCMH has been proven. These are just a few of these studies. If you look at this pcpcc.net, there's great information on there. You could spend the next couple months on it looking at the details of the different PCMH successes and the reduction in costs. So this information is from the MGMA, Medical Group Management Association. Just a little bit about that organization. TeamPraxis is a member of that organization. Over 22,000 members nationwide. They manage over 13,000 organizations, healthcare organizations, and that represents somewhere around 280,000 physicians across the nation. And they are over 40% of healthcare services in the U.S. are represented by that slice. So when they do a survey, it's very well represented as far as their surveys are to their members who have a vested interest in communicating, because then they get the results back. So what we saw in the PCMH status, I like to lump these top two together, right? Because they don't know or they're not interested in PCMH. So there we have about 11%. As we look at these next two, transforming already to become a PCMH or accredited, that's 48%. So that is by far leading any of these categories. Next is they're interested, so 41%. So we can see PCMH is really getting traction across the nation. Now this next slide, I just want to focus in on this because this is what TeamPraxis is interested in locally, is really facilitating this change for the independent physicians, those that own their own practices. So as far as accredited or recognized, over half were physician-owned. So that's really huge to know that that's getting traction in that independent physician market. And the challenges, these are, when we look at this top one and this one, they're business sustainability challenges. So they don't know the impact of these new reimbursement models. How are they going to finance this change? Here we have just adapting to technology as a challenge. Coordinating care for high-risk patients. And this is, logistical, but then also I think it really ties in here. It also talks about the relationships, establishing care coordination agreements. And as we see health information exchanges come around, especially in the independent physician community, one of the biggest concerns is I need to make sure I have an agreement that reflects what's going to happen with my data. Independent physicians are really sensitive about their data, and they're really wary about, is this going to be used against me? Am I going to be judged by some way on what's perceived as negative performance on these measures? So that's one of the obstacles that really needs to be overcome to pull everything out of these silos in the independent physician world. So lastly, how does this relate to what's going on in Hawaii? And in Hawaii, we see increased, and we already saw that we have great adoption rates here. So we see increased adoption. We see funding on the Beacon, Big Island getting a lot of funding. HMSA's really gotten traction with their pay-for-quality programs, with their PCMH. They've done an unbelievable job. And that really, we see that tremendously because physicians, PCMH is focused on selecting quality improvement projects to make headway on, be it diabetes, heart disease, asthma, preventative. So we see those physicians going through this PCMH process with HMSA and then saying, how do we do this? We can't do this with our paper charts, or we have an EHR, but we need help on the reporting. So they've really gotten good traction there. The HHIE has selected Medicity to do the statewide HIE. So, and then the Hawaii Pacific Regional Extension Center is out there essentially helping these independent physicians get to EHR. And then lastly, that brings us to us, TeamPraxis, and what we're doing with CQS PHM and our partnership with Microsoft and Amalga. So that is where we got the Qualifying Therapeutic Discovery Project. And what this was, it was under the Affordable Care Act. They had $1 billion that they said we're going to give tax credits, or if you were to choose, grants for organizations of less than 250 employees that have made progress in this way of technology that's going to improve health, reduce costs. So TeamPraxis, we were awarded over $244,000, a tax credit for 2009 and 2010, and it was because of our clinical quality solution, PHM, population health management piece, that helps diagnose disease. It helps provide proactive care more effectively. And so a little bit of a history of CQS. We started this back in 2007. We steered our software development efforts towards this. It's rebranded and sold nationally by Allscripts. So really allows us to leverage the economies of scale to bring the best solution to Hawaii physicians, because we never, if we were just in the Hawaii market, we never could put together this sophisticated a solution at an affordable cost. So I'm going to focus right now just on these channels, because it started at PQRS, Physician Quality Reporting System, and we had incredible success with that. We had 100% success. We also were a CMS registry, so we gave them the technology, independent physicians the technology to keep track of these measures, numerator, denominator measures, and then we reported that to CMS for them. So we had 100% of physicians that participated in this got checks, which to me is amazing, because I've talked to a lot of other physicians in Hawaii that say, oh, we tried for PQRS and we never got any checks. And that was a lot of the thing when Meaningful Use came out. It was like, how do we know we're going to get our check? Well, I never got my check for PQRS, but we had 100% success, and it really has to do with that business model of saying, hey, we're able to leverage the mainland market to bring the best solutions to Hawaii. So Meaningful Use, the measures ended up looking very similar. As far as it's the core measure 10, report clinical quality measures to CMS, that ended up looking very similar. Once again, numerator, denominator measures, and was really similar to this PQRS program. But what we saw was these weren't necessarily the programs that physicians needed to have a bottoms-up effort to manage these chronic diseases. They're what CMS needed for their reporting needs, but they weren't proactive. They were all backward-looking measures. I mean, that's one huge problem of these programs. How do I see that patient ahead of time when I want to know before they need their A1C. I don't want to know that their A1C didn't happen on time or that it did happen on time. I want to know that it needs to happen in 3 months, so I need to make sure I proactively take care of that. And that's where we went into this PHM area. And just to let you know about the national model, this is our footprint across the nation. So took us 18 years to get 1,000 physicians using our system, and then in another couple of years we had over 10,000. So really leveraging that partnership, and once again, all the benefits of that for Hawaii is being able to bring that affordable solution here. So the focus of our PHM channel is really aligned with the focus. I mean, we did our market research. One of the great things about having that mainland footprint is we're able to do market research with our existing clients. We're able to talk to our existing clients here in Hawaii and say, okay, what is needed? And what we saw was really good alignment, that diabetes, heart disease, asthma, and prevention, those were really the low-hanging fruit of what those chronic conditions represented. And that's where we could have the most, say, return on investment quickly. So, and our whole goal was to improve outcomes, to improve efficiency, to allow physicians to not only do this, but do this in an efficient way. So that's really the goal of what PHM is. And what it represents clinical decision support at the point of care. It also has a piece that is pursuit lists, so registries. So it also helps you manage that population health management piece of the patients that you don't see. So at the point of care, I didn't put any of the pursuit lists on here, but here's what you see at the point of care. And it's measure driven. We have two different types of measures, health goals and care actions. So they're goal measures and process measures. So up here on the health goals, we can see that, okay, the A1C is up to date. That doesn't have anything to do with the value of the A1C. The A1C could have been 12 on this patient, but I'm still going to get a check mark because it's up to date by the standard. But what we see down here is a goal measure. So I'm getting a check mark because the A1C is below 7. So if it's above 7, then I'm not going to get a check mark. And then I can see for this patient, what are the populations? The patient's hypertensive and diabetic. And that drives what care action and health goals we're going to see here. So this is just a quick view of the dashboard at the point of care. Like I said, there's a lot of other functionality in this. But so here we talk about the process measures and goal measures and the difference between these. We talked about how we focused on diabetes, heart disease, asthma prevention. Here's the different measure counts that we implemented for each of these. As you can see, most of them are process measures. We separated out what's goal measures. So, if I subtract 1 from 5, I get 4 there as far as my process measures. So there are 4 process measures, 1 goal measure. And, I know those measures off the top of my head. They're foot care visit, eye care visit, nephropathy visit, A1C up to date. That's my process measures. Then the goal measure is what was the A1C value? Was it below 7 or above 7? So it's the same thing as you get into asthma, heart disease, and prevention. And there's overlap in there too, because a lot of the prevention is, the goal of a lot of the prevention is to keep them from being in this heart disease category, to keep your patient from being in the diabetic category. So. Now, as I move on, so then to talk about how our Microsoft partnership and Amalga align with this. So Amalga is a very sophisticated analytics platform. It also allows for more of pulling the practices out of these silos. But what it didn't have as much of was what we were strong at, and that's clinical measure intelligence. That's essentially what population health management is, our CQS-PHM channel. It's clinical measure intelligence. It takes that data in the EHR and it says, this is great. We've got tons of discrete data. We've got lab data. We've got data on, and it actually even pulls claims data out of the practice management system too. So it says, we have all this data, but how can I represent this in a way that helps the physician make a meaningful change for their patient? So clinical measure intelligence is really where the value of our CQS-PHM was. And then the value of just the manipulation of the data, and that's where Amalga was. So what we did was we fused these 2 products. And right now that's currently installed on 15 pilot physicians in Hawaii. They're having great success with it. When we demo this to people, we just get incredible feedback, and we're continuing to make it better every day. So it's something that we're definitely excited about. And this just gives you our comprehensive health IT stack. So a lot of the pieces I've talked about, where does it all play? We have a centrally deployed solution. So when I say we have over 220 physicians, they're all hitting one server up. So that makes things like interfaces to banks, to labs, to other ancillary services, radiology and whatnot, so much easier. And as we move forward into health information exchange, to getting physicians on this integrated CQS-PHM Amalga platform, and for any other health information exchange, it makes everything so much easier. So this is our centralized solution, and as we can see, we have our EHR. This is our CQS-PHM plus Amalga. Our patient portal, we're in the process of selecting and implementing right now, so we expect that to be out there really soon. And just that's going to be something that I'm looking so forward to, because with over 220 physicians on our system so far, the number of patients that you're going to be able to engage right off the get-go by doing one patient portal implementation is really going to be awesome. So we're looking forward to that. So lastly is, where do Hawaii's independent physicians fall in all of this? And let's see where we are here. So this is nationwide. Actually, if I was to say the solo and 2 physician practice, we have a lot more of those in Hawaii. Nationwide, it's 32%. 3 to 5, 15%. So there we have 47%. Main point with this, when we get to hospital-based physicians, we're talking 13%. No healthcare reform is going to be successful without these independent physicians, these small office-based physicians. And that is, it's what I've heard the term the last mile, because you got to connect this office, and really problematic if they've got a server on site. But the centrally deployed solution is so much more efficient to bring these physicians together. So the challenges that they see, and I talked a little on this earlier, it's really overwhelming for independent physicians out there now. And I'm out there talking to them every day. It's information overload. They feel like, I've got these huge business changes that I've got to think about. And I've got new care models that I have to think about. So I have to think about business sustainability, and the target seems like it's moving. And then I've got to think about continuing to care for my patients. So there's a lot on their plate. I think a lot of them are frustrated. I think it's gotten better, but I think we still have a long way to go. So I like to put this up there just to get a good visual of really what the independent physicians, the unique challenges that they have. So as far as the successes, these are some of the things that make it better. I tell you what, you get an $18,000 check and you're worried about business sustainability, then that's definitely gonna make it better. It doesn't resolve the problem, but then I think it also conquers a lot of skepticism about, is this real? Is this really gonna happen? And there definitely was a lot of that out there. So we saw in 2011, 40 physicians attested in Hawaii for meaningful use. 27 of those were TeamPraxis physicians, and they've all received their $18,000 checks. So we recently had an event, and they were really excited. And it's really great to see, because I know a lot of them have been our longtime customers, and we're really, really happy for their success. So right now, we have over 40 physicians in their 90-day attestation period. So a stage 1 meaningful use, you have to prove for 90 days, meet those measures, and then you attest online, then you get your checks. So we currently have 40 physicians in that attestation period. By the end of 2012, we're going to have over 150 physicians that will attest. And so that, to me, is a huge success, that we talk about those unique challenges that helps overcome these physicians' worries about business sustainability and some of their skepticism. This should be 2011. So 2010, 2011 was our PCMH pilot. So this is a little bit about the PCMH successes we've had locally. We saw some of the national ones. We collaborated with Queens, HMSA, Healthways. We had 24 independent physicians on this. And really, this is where you tie it all together. Because if you proved meaningful use, where are your clinical outcomes that we can show you because of that? I mean, you leverage technology to prove meaningful use. You're one step closer to where we need to be. And that's, you've implemented technology that will facilitate this change in care, that will facilitate you getting these low-hanging fruit, which are the people with multiple chronic conditions. But the success of this PCMH pilot was very encouraging. We had a lot of successes. I just wanted to walk you through one. And these 24 physicians got together with the support of all those collaborating parties and did quality improvement projects. They met regularly and they pushed the envelope. And this was one of their quality improvement projects, right? It's to make sure that they get their poorly controlled diabetics under control. And they had their benchmark here. Best in nation, approximately 6%. HMSA PPO, approximate 40%. HMSA Medicaid, approximately 50%. So they did their definitions of numerator, denominator. And you can see what those are here. And the success of this was, especially on this low end here, you can see best in nation competitive. So, I mean, to me, to see that we have, physicians, and healthcare in Hawaii is, you can look at the studies, it's outstanding anyway. I mean, we do a really great job here in Hawaii, but obviously in Hawaii nationwide, we need to improve on more proactively managing these chronic diseases. So this was a really, really good success to see them be able to really beat these benchmarks here. As far as to have a physician that was in that best in nation category. And it was really encouraging for us to say, hey, this PCMH model has not only shown nationally that it can be successful, but we've been able to leverage different parties and technology to make it a success here in Hawaii as well. Now, lastly, just wanted to sum it all up, because really this presentation is about the independent physicians and about their challenges. So a lot of this is information that I've already covered, and it doesn't by any means represent all the challenge they have, all the opportunities that they have. But really that business sustainability, and we saw it in the results of the MGMA study where 2 of the 5 concerns were more business sustainability concerns. We don't know what the impact of these new reimbursement models is going to be. We don't know how we're going to pay for them, you know? So in their new reimbursements and care models is really tied in with that sustainability. Really participation and coordination agreements. That's, as we go forward, that's going to be huge in saying, how do we define this new healthcare market, and how are independent physicians going to work in this new healthcare market, and what is the agreement that says this is where their business is going to benefit? And you know, HMSA has done a lot in their PCMH program and their pay for quality program to define these. But as we get more clinical information exchange, then it's really going to become more of a demand to define these. And then leveraging and adapting to technology, just in these small offices. I mean, these independent physicians, they don't have a chief information officer. They don't have a chief medical information officer. So they need other support. And that's really a challenge for, I mean, the independent physician offices, they're like snowflakes. No 2 are the same, you know? They're managed different, they're staffed different. I mean, you go into some offices, the doctor does everything. You go into some offices, the doctor has a staff of 10, and varies a lot between specialists and primary care providers. But at the end of the day, these are all independent physicians. And, you know, you can lump them into those specialty groups, and there's concerns in those different specialties. But as a whole, there's a lot of concerns that are consistent throughout the independent physician market. So opportunities, there's opportunities for new revenue streams. We see that with HMSA's PCMH program, and they've implemented their capitated per member per month payment for physicians to make that transition into patient-centered medical home. And cost reduction and improved care, and you know, I think the care is really, I don't think there's any physician out there that if they are served up the opportunity to say, hey, we can do things in a better way, they're going to do it. It's just removing these obstacles is the goal, and everyone really needs to pitch in to remove these obstacles. And the last is funding. This is one that I really want to raise awareness about locally, because I think I've talked with a lot of nonprofit research organizations. I've talked with Pacific Health Research and Education Institute. I've talked with a quality improvement organization, Mountain Pacific Health. I've been talking with the American Heart Association lately. And what my interest there is to say, independent physicians, I mean, you see the trends with the EMR, EHR adoption. Now you're going to be able to layer on top of that quality solutions, and you're able to pull them out of the silos. There, I think, we saw also the trends nationwide that 40-something% of care is delivered in this 5 or less physician-owned practices. So I think there's just tremendous opportunity for funding to prove models of care that oftentimes has always gone to medical institutions. But as far as, you know, the national organizations like ARC, their goal is to do new healthcare systemic change and to prove models there. So I think there's great opportunities on state, local, and federal to say, hey, how can we do projects that are funded to bring in more community resources to these physicians to help them make this change? And that's one thing I would definitely think is a great discussion. I've got a lot of positive feedback on that opportunity, because now that the technology is there, it's like the foundation is laid for this to be a reality. In the past, it wasn't there because you couldn't pull all these physicians with paper charts together and say, let's do a project. You know, you couldn't get access to the data. So all those, I think, are challenges and opportunity. And as a whole, this is what we see at TeamPraxis out there with our feet on the ground in the independent physician community, and how we see technology changing what's happening. So I have my contact information. I'll open it up for questions now, if any of you have any. Okay, go ahead.
Is it all right if I pass your information along to the Hawaii Primary Care Association?
Oh, yes,
definitely. I'm not sure if you're aware, but they've been charged with, by DHS to lead a collaborative to develop a state plan amendment to develop a PCMH model. So actually all of the health plans and a few other consumer groups have been working together over the past year to develop this model.
Okay.
To do a PCMH.
No, definitely do that. And is that what the meeting 2 Saturdays away, is that related to that? I know it's Dr. Kelly Withy's. Okay, it's a different, okay, gotcha.
So what's being done, I guess, on a statewide level through HHIE to really pull together all the different stakeholders to address issues of interoperability? Because you folks have your own system, Queens, Kaiser, I know they use Epic. So how are we ensuring that these different systems are able to talk to each other?
Yes. And you know, right now, I know they've made their decision that they're going with Medicity to connect all these different platforms. We are meeting with them, and I know they're out there meeting with the other stakeholders as well. So that, I think, is the process that they're at. And they've been meeting with everybody for a long time, but I think it's a different situation now that they've selected Medicity because they know the path forward. So at the end of the day, I think the first priority for that is really your continuity of care documents, continuity of care records. And I haven't really looked at their detailed plans, but I do know that I believe with the decision now that it's Medicity, I think we'll see things move a lot quicker in that direction.
And have you been working with the Hawaii IPA, Hawaii Independent Physician Association? I'm not sure if a lot of physicians are also aware that, you know, come 2013, it's mandated in ARA that EHRs have to be adopted, and if we don't, the state starts to get docked in their Medicare reimbursement rates. So, I mean, are these physicians aware of that?
We definitely make the different independent physician associations aware of that. We have a good customer base throughout, like, you know, Hawaii IPA, East Hawaii IPA, PMAG, and the Hawaii Filipino Healthcare PO. So we have that good customer base there, and every opportunity we get out there to get that information out.
I have lots of questions. Just to start, so you said nationally about 32% of physicians are solo or two-person. What do you think that number is in Hawaii?
You know, and I had meant to talk to the people at Hawaii Pacific Rec and Mountain Pacific Health to get their input. Like, honestly, if I was just to take a guess, and I might be really biased because that's our market, you know, but if I was to take a guess, then I would say that we're definitely 50% or above. Because you could. Yeah, I think that would be where I'm at. And, you know, I've looked at those numbers a lot because that's our market, but I've never found a definitive source that says this is what it is. But, you know, there's a lot of information out there. I know Senator Josh Green is always out there with the numbers about the physician shortages. So you can see, okay, 2,800 something physicians, we're 700 short. And then I'm able to take my numbers and say, okay, you know, I think we're right over 50% on.
My concern is that a lot of these models, like capitation or ACOs, shift the risk to the physicians or to the hospital. And if you're a solo practitioner with a fairly small patient pool, you aren't going to be able to absorb that risk. So I totally support what you're saying about some funding to kind of help physicians. You know, I don't quite see a vision for that yet here in terms of what people are talking about. But I think it has to happen if any of these models are going to work.
No, definitely, and you're 100% right about that. And I mean, physicians see that too. They're a small pool. I can't take on risk. But I think that's where, you know, as the ACOs develop, that's where the hospital physician alignment is, because, okay, or the IPAs even, because the ACOs, as far as who can play in the market, is very broad, you know? So you could get that risk sharing piece more at the IPAs, and then you know how we have the process and goal measures, and it could be a target that moves, but then you could say, all right, you're more focused on the process measure. So we know if we stick with evidence-based medicine that says if you're a diabetic, you need to get your A1C, your foot exam, your eye exam, that we're going to reduce costs right there if we can get compliance for these process measures. But that's a very valid concern, and it's a concern that's out there for the independent physicians. And I think, you know, that's where the moving target is really. I think everything is in place for that new healthcare market to accommodate for that, but then it's who's going to be able to really create the right participant agreements for an ACO that can offset a lot of that concern.
I have a lot of concerns about this from a consumer standpoint. As a healthcare consumer, it seems to me lately there's been a lot of pressure to get screenings, right?
Yes, yes.
I'm hearing that from my primary care physician. And then on the other hand, what we're hearing about every month, we're hearing that some screening has been found to be either ineffective or too expensive because of the technology advancing all the time, or even harmful for
Yes.
that matter. So physicians feel pushed into these screenings, perhaps, and as a consumer, I feel like I'm also being pushed into into taking action that I feel I don't want to take for one reason or another. And then in addition to that, some of my other concerns are around, well, you mentioned it yourself, some physicians are concerned, primary care physicians are concerned that they'll be rated and that this will be used in some punitive way against them. And eventually, something like that, for this system to work, there is going to have to be some kind of consequence if enough physicians don't get on board. I mean, whether it's anecdotal or systemized or financial, if this system is dominant, then those who don't buy in are going to be on the outs. And that brings up a sort of meta concern, meta criticism here, which is that healthcare reform is supposed to be one of the main goals that we all share is to create a more positive interaction and relationship between the patient and the doctor. And one of the major criticisms of the Affordable Care Act has been not that people don't want better health care, but that they see themselves as being pushed into purchasing health care from a big corporation, right? And I don't have to agree with that criticism, but that's the feeling of a lot of people, that they're going to spend the rest of their life being put on hold for an hour and a half trying to reach not their doctor, but their insurance company. So I don't have to agree with that, but I can understand that. So now all of a sudden we have another big corporate entity coming in the form of this system. And so that's another corporate fly in the soup for people to deal with. And I know you said that the articles about this whole new system have been largely positive, but can you address some of these criticisms?
No, definitely. No, they're all very valid concerns, and I think your voice is definitely heard. And the reason I can say that is because if we go back to that healthcare leaders survey, the number one thing on there was customer satisfaction. So there's a lot of people out there expressing the same concerns as you, a lot of people that feel the way you do. So they're all very valid concerns. I think, first off, I know one of the big things that always goes back and forth is mammograms, right? And so I think, too, it's real, and I think you need to, it's unfortunate, there's a lot of miscommunication, but I think from that perspective, there's a difference between the model of care and these pieces like mammogram. Now they need to straighten this out, but I know from the concerns of mammogram, it's gone back and forth a lot because they say there's so many false positives and the false positive has such a negative impact. So they wonder, they're trying to weigh the benefit of all the negative impacts of so many false positives when the minority of them end up being cancers. So there, I think in a specific instance, we can see that it's kind of deep what they're trying to figure out in that area. But then there's a lot of areas. But I understand how that is frustrating. And the only, I guess, light at the end of the tunnel that I can say is, I think in times of change like this, and I mean, this is an enormous change, you're going to get a lot of miscommunication. Now that mammogram one to me is something that would have happened besides for healthcare reform. Healthcare professionals would have been out there debating that if they never had the Affordable Care Act. But from the healthcare system and the change there, the one point of positive that I see from the patient-centered medical home is it's focused on engaging patients, and giving patients choice. That's the guiding principle of it. So, and there's a lot of other access to care, so it's another. But when you look at the guiding principles of it, they're saying, okay, my patient has this chronic disease. I give them choices. You can do A, B, C, or I give them choice D. You can do nothing. The choice is yours, but these are your options. So what a lot of the patient-centered medical home research has shown is that not only these positive outcomes here, but one of the most interesting things that I find out is increased job satisfaction from patients. I mean, from clinical staff, from physicians. It also shows, everyone's always talking about tort reform. These patient-centered medical homes, some of them have shown that they have less lawsuits when they engage the patient. So when they ask the patient to partake in the care, when the patient sees mistakes, they're more forgiving because they say, this wasn't your plan for me, this was our plan for me. So I know that doesn't really answer your question, but I think there's some light at the end of the tunnel. There's some really positive data out there that shows that there is great potential for positive change with these. But I think it's one of those things that you need to keep your voice heard, and there are healthcare consumers out there doing that. Definitely let people know that, hey, I'm unhappy about this, I'm unhappy about that, because you know what, if the healthcare consumer wasn't represented, then these health leaders, that wouldn't have been at the top of their list as far as customer satisfaction. So without you making sure that without you getting that out there, that this is frustrating from a consumer level, then things aren't going to change. So I don't know, I hope that was helpful.
Just want to do a time check.
Yeah, so we're kind of closing in on time. We got some other business for the meeting.
Okay.
If there's any other questions, please forward them to Karen.
Or
yeah, and you can email me directly. I mean, this is great. I really like to get out and hear the different input that people have, because that's, to me, I mean, you can read 1,000 articles, but where the real learning happens is when you get to engage people and find out their opinions.
Well, thank you very much.
Okay, thank you very much.